Good evening, everyone. Myself, Dr. Madhu, Academic Head Emergency Medicine, Yashoda Hospital, Somajigoda. It gives me great pleasure to welcome you all to today's academic session, organized by Department of Emergency Medicine, Yashoda Hospital, under the Experts Appraisal on Emergency Medicine series. This platform is designed to focus on practical, evidence-based discussion on high-impact emergency conditions that we encounter in our day-to-day practice. Today's topic, upper gastrointestinal bleeding, remains a time-sensitive emergency requiring prompt assessment, resuscitation, and coordinated care. We are confident that today's session will add clarity and practical value to our clinical decision making. Let me introduce our speaker, Dr. Y. Vamshi, Consultant Emergency Physician at Yashoda Hospital, Malakpet. I now invite Dr. Vamshi to take us through the topic. Over to you, Dr. Vamshi.
Thank you, sir, and good evening, all. This is a great opportunity for me to be a part of this learning platform. Today, I will be speaking about this upper GI bleed, which is a day-to-day encounter we will have. And yeah, so coming to upper GI bleed, any GI bleed which occurs from source proximal to the ligament of trace is called as an upper GI bleed, starting from the mouth up to the duodenal junction. And pathophysiology, most of the causes of upper GI bleed are peptic ulcer disease, erosive gastritis and esophagitis, esophageal and gastric varices, Mallory-Weiss tear, Dieulafoy lesions, and arteriovenous malformations. So coming to this peptic ulcer disease, it is the most common cause of UGI bleed, and this happens due to repeated infection and irritation that leads to disruption of mucosa. It includes gastric, duodenal, esophageal, and stromal ulcers. The hemorrhage occurs from the erosion to the blood vessel from ulcer base. Smoking, NSAIDs, aspirin, and H. pylori infection are the common risk factors. And coming to erosive gastritis and esophagitis, predisposing factors include alcohol, salicylates, and NSAIDs. Infection, toxic ingestion, radiation, and stress from severe illness also causes erosive gastritis. Esophageal and gastric varices, caused by portal hypertension, which in turn is caused by liver diseases like cirrhosis, alcohol, liver disease, etc. And it is less common cause, but they can rebleed and carry a high mortality rate. Mallory-Weiss syndrome, mucosal or submucosal tear at the gastroesophageal junction. Typically, patient has history of repeated vomiting, retching, followed by bright red hematemesis. And the risk factors include alcohol binge drinking, DKA, chemotherapy, Valsalva manure, and coughing. Dieulafoy lesions. These are the arteries of GI tract that protrude through the submucosa, usually present near the gastric fundus within 6 centimeters of gastroesophageal junction. Patient present with intermittent and massive GI bleeding without any predisposing factors such as liver disease or NSAID use. Other causes include arteriovenous malformations, malignancy, arterioenteric fistula secondary to pre-existing aortic graft. Significant bleed from ear, nose, throat sources can also masquerade as GI bleed. Diagnosis. Proper history is important. Coffee ground emesis suggests an upper GI bleed. Melena and age less than 50 years old more likely indicate an upper GI bleed. Vomiting and retching followed by hematemesis suggests a Mallory-Weiss tear. A history of aortic graft should suggest bleeding from an arterioenteric fistula. Salicylates, glucocorticoids, NSAIDs, and anticoagulants, alcohol abuse all place the patient at high risk of GI bleed. Iron and bismuth can simulate melena. Examination. Most reliable way to diagnose upper GI bleed is by visual inspection of the vomitus for a bloody, maroon, or coffee ground appearance. Vital signs may reveal hypertension and tachycardia. Cool, clammy skin is an obvious sign of shock. Spider angiomas, palmar erythema, jaundice, gynecomastia suggest liver disease. Petechia and purpura suggest an underlying coagulopathy. Abdominal examination may disclose tenderness, masses, ascites, or organomegaly. Perform rectal examination to detect the presence of blood and its appearance, whether bright red, maroon, or melanotic. Investigations include complete blood count for hemoglobin and platelets, LFT for liver disease, PTNF for coagulation, renal function test, blood urea nitrogen and creatinine ratio more than 30 suggests UGA source of bleed. A single elevated lactate level is a sentinel sign of severe illness. Barium contrast studies are contraindicated because barium may hinder subsequent endoscopy or angiography. UGA endoscopy, capsule endoscopy, target red cell scintigraphy, and visceral angiography are the significant investigations to rule out bleed. Nasogastric lavage. Nasogastric lavage performed before endoscopy may improve visualization by removing clots and blood, but it is associated with the risk of aspiration and GI injury. Risk stratification. There are certain scoring systems to know how where the patient is placed, such as Glasgow-Blatchford score, which includes blood urea nitrogen, hemoglobin, systemic blood pressure, and other markers such as pulse rate, Melena, syncope, hepatic disease, and heart failure. So the total score comes around 23. Anything greater than 0 is high risk and needs intervention. And anything greater than 8, patient should be admitted to ICU, as the patient is at risk of rebleeding more than 50%. There is also score AIMS 65, which includes albumin, INR, altered mental status, systemic blood pressure, age more than 65 years, and the maximum score is 5. There is also Rockall score, which includes age, shock, comorbidities such as cardiac failure, renal failure, liver failure, and malignancy, endoscopic findings, and diagnosis. So the total score is around 12. Less than 2 puts the patient in low risk. So usually 80% of the patients recover spontaneously with medical treatment and hospitalization for 48 hours. A score 3 to 5 is at moderate risk with the same treatment, but hospitalization is prolonged for 72 hours. And any score more than 6 is high risk and patient needs ICU admission. Treatment. So GA bleed patient is at risk of rapid deterioration. Empirical treatment involves prompt resuscitation, consideration of platelet transfusion, pharmacological therapy, and early consultation of gastroenterology. We need to secure 2 large bore IV catheters. Unstable hemodynamic patients like tachycardia, hypotension, and drowsy should have crystalloid fluids rapidly infused. Early intubation in massive GI bleed is indicated. Blood transfusions. If need of large amount of blood product is anticipated, use massive transfusion protocols. Transfuse if HB is less than 7 grams in most of the patients and less than 9 grams in older patients or with comorbidities. Coagulopathy. Correct if INR is elevated or platelets less than 50,000 of bleeding or if bleeding is severe. Correct coagulopathy with FFPs, cryoprecipitate, vitamin K, and specific factor concentrate unless contraindications to correction such as patient is non-CAD with post-PTCS status or having wall replacement on warfarin. Tranexamic acid in a small systemic review study has been shown to reduce the risk of death in patients with upper GI bleed. Proton pump inhibitors. When PPIs are given at high dose, the gastric pH remains neutral. And this helps with the clot formation as platelet aggregation is dependent on pH more than 6. Omeprazole 80 mg stat followed by 8 mg per hour infusion is a regular protocol we use. And it reduces the need for surgery, length of hospital stay, and signs of bleeding and peptic ulcer disease. Somatostatin analogs and octreotide. Octreotide is a long-acting analog of somatostatin. It inhibits the secretion of gastric acid, reduces blood flow to the gastroduodenal mucosa, and causes plant-linked vasoconstriction. 50 microgram bolus followed by continuous infusion of 25 to 50 micrograms per hour is a regular dose. When combined with early endoscopy, it may reduce bleeding. Telepressin is more potent with significant reduction in mortality. Dosage of 1 milligram TID. Antibiotics. Liver cirrhosis patients have an impaired immune system and have an increased risk of blood bacterial translocation. Prophylactic antibiotics such as ciprofloxacin 400 mg IV or ceftriaxone 1 gram IV reduce infection complications, rebleeding, days of hospitalization, mortality from bacterial infections. Promotility agents. Erythromycin and metoclopramide are used to enhance endoscopic visualization. They can be used when the patient is undergoing endoscopy in the ED and the patient is suspected to have large amount of blood in the upper GI tract. Non-medical treatment. This includes upper GI endoscopy, balloon tamponade, and surgery. Upper GI endoscopy. Upper GI endoscopy is a diagnostic study of choice. Can identify source of bleeding and administer hemostatic therapy. Early endoscopy within 6 to 24 hours of presentation for unstable patients for adequately resuscitated and 12 to 36 hours for stable patients is recommended. This decreases in-hospital mortality, a significant cost reduction, and decreased length of stay. Variceal bleeding we can treat with variceal ligation and sclerotherapy. For ulcerative lesions, clips, thermocoagulation, and sclerostin injections are used. Balloon tamponade. This is an effective short-term solution for life-threatening variceal bleeding. It is reserved for temporary stabilization of the patient, for transfer to an appropriate institution, or until endoscopy can be done. The sense-taken Blakemore tube, which has 250 ml gastric balloon and esophageal balloon and gastric suction port, and Minnesota tube with an added esophageal suction port above the esophageal balloon, can be used for balloon tamponade. Surgery. In variceal bleeding, two types of operations can be done. Shunt operations, such as transjugular intrahepatic portosystemic shunt procedure, and non-shunt operations such as esophageal transection or gastroesophageal junction devascularization. For non-variceal bleeding, percutaneous embolization or subtotal total gastrectomy the options. Thank you.
Thank you, Dr. Vamshi, for the well-structured presentation. We'll now proceed to the question and answer segment. I request the audience to keep their questions concise and relevant to the topic. You can post questions in the chat box, or you can ask directly. We will wait for a few minutes and we'll answer if any questions from the audience. Okay.
Ciao.
So in variceal bleed, so which one you will prefer? Octreotide or somatostatin or terlipressin?
Telepressin, sir, for recent studies show telepressin is more potent, and we can give as a start dose followed by TID doses, which will help in the mortality reduction compared to octreotide.
Okay, so
But one is costly
is
compared to
there any
octreotide.
contraindications for terlipressin?
Sorry, sir.
Any contraindications for terlipressin? Usually when patient has cardiac history or ECG showing some ischemic changes, so
Sure.
we have to avoid the terlipressin. Rest of the patients,
No.
otherwise terlipressin is the best choice, especially in
No.
the vessel bleeds.
Sure.
Any questions from the attendees? Okay, I think no questions from the attendees. So, do you want to add anything, Dr. Vamshi?
Yeah. For now, I mean, I thought I have covered most of the points for now.
Yeah, you have covered most of the things. So, okay, so as attendees have no questions, so we'll conclude this session today. Thank you once again, Yashoda Hospital, for supporting the academic sessions like this. And thank you, everyone.
Thank you for this opportunity.
Okay.